Hi, my name is Dr. Raina Merchant, and I'm the chair of the AHA Emergency Cardiovascular Care Committee. And I'm really excited to be joined by several colleagues to review the highlights from the really incredible Scientific Sessions Symposium. I'd like to first introduce Dr. Ben Abella.
Hi, my name is Dr. Benjamin Abella. I'm a physician at the University of Pennsylvania, and this year I was the co-chair of the Resuscitation Science Symposium.
And Dr. Mike Danino.
Hi, Mike Danino. I'm an emergency medicine and critical care physician at Beth Israel Deaconess in Boston, and I am also a co-chair of the Resuscitation Science meeting this year as well.
And Dr. Diane Atkins.
And I'm Dr. Diane Atkins, a pediatric cardiologist and electrophysiologist at the University of Iowa. I'm the current vice chair for the Emergency Cardiovascular Care Committee, and I had the privilege of serving on the writing group for the pediatric guidelines this year.
So I'd like to just ask a few questions. Maybe Dr. Benabella, can you start out with giving us some of the key highlights from this past ReSS symposium?
Well, there's so much to say there. I'll give a brief little overview. So the Resuscitation Science Symposium this year was a 3-day meeting, of course, fully virtual, and we had a mix of live sessions, abstract sessions, late-breaking science, many of the usual programmatic aspects. And it was actually pretty successful considering it was in the virtual format. Some of the highlights from the meeting that really stood out to me there were several sessions and abstracts and original science presentations related to COVID-19 and the effect of COVID-19 on the landscape of cardiac arrest care. And I would just highlight a few of them. One of them, quite striking, in the out-of-hospital cardiac arrest setting, Paul Chan and colleagues looked at survival in the era of COVID. And they found, perhaps to not much surprise, but it was really quite striking, that survival fell greatly in the CARES registry when compared to a previous time period before COVID. And they did a number of statistical evaluations to look at that, and it held true. And it was even more true, that is to say, there was a greater drop in areas that had a higher COVID mortality, suggesting that there was clearly some interaction of local COVID burden and fear and concern and survival. And so that is really worrisome and speaks to issues of understanding of pre-hospital care. One of the mechanisms may have been increased termination of resuscitation, which they found had gone up a lot in COVID areas. Now, conversely, another late-breaking science abstract looked at the risk of COVID transmission in EMS and found it to be vanishingly small, even when EMS providers were exposed to aerosol-generating procedures. And so that work, combined with the work from Paul Chan, suggests we have a real disconnect, and it speaks to an implementation and an educational disconnect. The other area that I'd like to highlight for a moment are some very promising and intriguing studies on post-arrest care. As many of our listeners know, one of the cornerstones of post-arrest care has been for quite some time the use of targeted temperature management. Some call it hypothermia or cooling after resuscitation. Well, one of the things that has lagged behind is pharmacologic adjuncts, drugs and other interventions to go along with targeted temperature management. And in this year's REST, we had 2 very exciting studies. One, a randomized trial of a drug tocilizumab, an IL-6 inhibitor, done in Denmark, that found that this drug seemed to have a striking benefit on cardiac function hemodynamics in the post-arrest phase. Another study from the Children's Hospital of Philadelphia showed that inhaled nitric oxide in a model of cardiac arrest showed very promising hemodynamic and other benefits. And so I think we're just at the cusp of seeing important pharmacologic therapies become proven and hopefully clinically available in coming years. And this REST, I think, had some excitement beyond just targeted temperature management.
Thank you so much, Dr. Abella, and for the incredible work in bringing all of this late-breaking science together at this very well-attended and engaging symposium. I'd like to turn it over to Dr. Mike Danino, and maybe you could share, as also a co-chair, some of the areas that really stood out to you as highlights to talk further about.
Yeah, thanks. I mean, I think one of the other things is that there's been a lot of interest lately, I think, among certain things such as double defibrillation or dual defibrillation. It's been a hot topic, largely driven by a number of case reports that have, suggested that this might be something that's advantageous in refractory ventricular fibrillation. What is exciting is we had Dr. Sheldon Chesky's present on behalf of his group, and he shared with us some of his pilot data, which has already been published, but it was interesting again to see him put it together and show that there was, in that pilot data, it looked like there was an increased return of spontaneous circulation in those that got double defibrillation. But again, this was just kind of pilot. What he did then start to tease us with at this meeting is some of the data from his follow-up trial. And what was, he didn't show us any outcomes to that trial, and it still is ongoing, but he did share I should say overall clinical outcomes, but he did share some insight into return of spontaneous circulation. And in what he did share with us, there looked like there may have been even a more pronounced treatment effect and increased return of spontaneous circulation in those who had double defibrillation. So I think that's an interesting topic that's continuing to evolve, and we're going to, keep a close eye out for the results of his trial. It's exciting, and glad to have him present it for the group this year. I also thought, also in the area of exciting new trials in out-of-hospital cardiac arrest, is the work that's being done by Dr. Yiannopoulos and colleagues. Dr. Bartos up in Minneapolis. And Dr. Yiannopoulos presented his work on eCPR, again, in patients with refractory ventricular fibrillation. And they presented results of one of their randomized trials. The trial was actually stopped by the Data Safety and Monitoring Board because of the efficacy level that was running in the treatment arm. They had only enrolled 30 patients. But of those 30 patients, there was 15 in each group, one that had eCPR and early revascularization in a very select group of patients. But nonetheless, within this population that they selected for and were randomized to 15 and 15, it was very striking to see that there was 6 survivors, or almost 43%, in the intervention arm, and only 1 survivor in the non-intervention arm. And so for that, they actually had to stop their trial early because they're doing such a good job. And the results, again, for those who are interested in diving a little bit deeper, again, can go back and look at both of these on demand, but look at further details in the on-demand settings where we've recorded these lectures. But again, just very fascinating data. I think one of the biggest questions that's going to come out of this is, where do we go now, particularly with the CPR? What they're doing in Minneapolis is fantastic work, but it's a very well coordinated system. I mean, in addition to the results being impressive, the mere operation of the treatment arm was impressive. How quickly they were able to get patients to a cath lab and get them revascularized while CPR is going on, and get them on ECMO. So it's just incredible timing, incredible work, but a lot of questions now for the resuscitation community. Where do we go from here? How does that and can that apply to other settings? What are other systems that can incorporate something like this? Could they pull off the same numbers and results that are being shown in Minneapolis? But very exciting work, and I think, again, more to come.
Thank you so much, Dr. Donino. It was, in fact, really exciting, and I'd encourage everyone to definitely look at the on-demand sessions. And then finally, Dr. Atkins, could you share with us some of the highlights for you from this ReSS Symposium?
So I'm pleased to be here. I'm going to talk about 2 different subjects. One is the need for us to recognize survivorship. And then I also will briefly talk about some of the new highlights from the adult and pediatric guidelines. The very first session of ReSS this year was on survivorship. And And I think it's something that we as acute care doctors have neglected. But Michelle Gossip at the Virginia Commonwealth University presented their results with an excellent program of providing a lot of support, physical therapy, occupational therapy, rehabilitation services to patients within the hospital, but predominantly after they leave the hospital. And it's not surprising that patients who have suffered a cardiac arrest and survived leave the hospital with a lot of fear, a lot of anxiety, as well as any possible deficits from the event itself. And this is especially true for their family members, those who may have witnessed the event, have provided CPR, have seen the actions of the EMS providers. There is a lot of anxiety, PTSD, and she presented their very coordinated program to help the patients. And the most interesting thing was to hear Dr. Will Flannery, an ophthalmologist who had suffered a cardiac arrest several months ago, confirming that indeed there were a lot of issues like that when he went home. And so that is something that I think we really need to improve our ability and improve our care for the long term for these patients. The second thing I'd like to talk about is the release of the comprehensive guidelines in October of this year. Both the adults and pediatrics worked very hard to provide those comprehensive guidelines. And there are some changes that I think are worth noting. The first is that both groups now have two chains of survival, one for in-hospital cardiac arrest and one for out-of-hospital cardiac arrest. We know that the etiologies of those two are different and the outcomes are different, and therefore the chains of survival need to be a little bit different. Both start out by either early activation or prevention. Early activation in the hospital is getting help. Early activation outside is calling 911. But we also talk about the usefulness of some of the phone apps to locate potential rescuers very close to the victim. And with the notification on their phone, they can often arrive at the victim's side before EMS arrives. The other big change is that we now have algorithms in both the pediatric and the adult guidelines for opioid addiction with the use of naloxone, especially for respiratory arrest or respiratory distress. In the adult guidelines, there now is an algorithm for cardiac arrest of the pregnant woman, with the emphasis that this is a team approach, that neither just a cardiac arrest team nor the obstetrical team can handle that arrest. And there is discussion of being prepared very quickly for perimortem delivery if ROSC is not achieved within the first several minutes. So both of those are well worth looking at. All of the guidelines now have a link for recovery, which is similar to the survivorship, recognizing that these patients do have long-term needs, physical therapy, occupational therapy, perhaps some cognitive testing and intervention, as well as psychological support. So we emphasize that much more so than we have in the past. In the pediatric guidelines, I do want to emphasize that our biggest change is on breaths per minute. Previously, we had followed the adult guidelines of 8 to 10 breaths per minute because of the potential negative effects that positive pressure ventilation have on hemodynamics during CPR. And we did that because there was no pediatric data, and we just accepted an extrapolation from the adults. However, we now have from the Children's Hospital of Philadelphia pediatric data that shows that children had much better survival with respiratory rates of 20 to 25. And therefore, we have now changed the recommendation so that when rescue breaths are given, that rate is at 20 to 25. There is a lot more in those guidelines, a lot more on post-cardiac arrest care. We continue our very strong emphasis on high-quality CPR, and I would really encourage everyone to take a look at those guidelines and incorporate the changes into your current care. So thank you so much for listening, and I hope this was beneficial.
I'd like to thank my colleagues, Dr. Benabella, Dr. Mike Danino, and Dr. Diane Atkins for providing this ReSS highlights, and I'd encourage everyone to definitely revisit the sessions on demand. Thank you.
Thanks very much.
Thank you.
Thank you.